Okay, hi, welcome to Mad Medicine, and I'm going to jump right into it today because apparently I only have 22 minutes. That's the best it gets. My phone shuts off, and apparently also certain individuals don't have an attention span longer than 5 minutes, so I may lose you after that. But for those of you that do have a little bit of an attention span, focus. We're going to jump right into it. So we left off on assessment with the heart last week, and today we're going to start with your lungs, right? So right after your heart, try to stay head to toe. Right after your heart, you're going to the lungs. So the first thing you're going to notice is that the respirations are even and unlabored, right? That doesn't mean that the breaths are even or they're taking the same breath each time. That means that there's an even rise and fall to the chest, so that one lung isn't going up and down and the other one isn't, which means we would have some sort of pneumothorax, collapsed lung, massive atelectasis unilaterally, which, can happen. So make sure you're watching for the even rise and fall of the chest, that the respirations are even and unlabored. Labored does not mean using accessory muscles when that little old lady is using her belly a little bit. When we talk about labored, remember, labored means work. If they are working to breathe, you don't even necessarily see it here. You see it here. They are wide-eyed. They can't catch their breath. They're scared. That's where your labored breathing comes in. Now, some COPD patients that have had issues for years and years, and they're just kind of used to not being able to breathe, which is bizarre, I know, but they do exist. You might see it in the chest as well, but when we talk about labored for the most part, that means they are working to breathe, not necessarily shallow breathing or tachypnea or that sort of thing, but labored means they are working to breathe, and you'll usually see it in their eyes first. They're wide-eyed, they're trying to do some pursed lip breathing, they can't catch their breath. That's when we talk about labored. If you're iffy about how to describe it, ask someone and see if they can help you kind of decide whether that's truly labored breathing or is there another way to describe it, or if you can get them. There are dramatic patients out there or people that are just nervous, anxiety, they can't control it. If you can get them to slowly deep breathe with you, say, watch me, breathe with me. If they're able to control it, then it's probably not a labored thing and it's more of a mental thing. So you can work with that. Also make sure they have their oxygen on if they're short of breath or anything like that. If it's because they're desatting because their oxygen fell off their face, hit the floor, that happens. So make sure that that's not an issue also. So then we talk about breath sounds. Now we may only get to breath sounds today and not even get to the abdomen because breath sounds are really, really important to understand. It's not just the sounds you hear. And, you're lucky enough to have a computer in your hand where you can go to YouTube and say, what a crackle sound like, what a rail sound like, what is a wheeze, what is a pleural friction rub, what does rhonchi sound like? It's not just so much what it sounds like, it's that what does it mean? And this is kind of a general explanation, and usually I draw pictures for my students to kind of explain that generally when you hear, we're going to kind of talk about it in three stages. So or three categories, your wheezing, rails, and or your wheezing, rhonchi, and your rails. Doesn't mean they can't be in other areas, but for the most part, where we kind of find them is because of the nature of the diseased lung or what's happening, the disease process, the etiology of where those sounds are coming from. Not just what do they sound like and where are they, but why are they there and what is happening to the lung when we hear those things, right? So the first and most concerning sound is an inspiratory wheeze. And I hear, students write this all the time. I've even seen nurses write it like an inspiratory wheeze in bilateral upper lobes, like it's nothing. An inspiratory wheeze means they can't get air in. That is more or less an asthma attack. Now, there are pulmonary patients and COPD issues where you may have an inspiratory wheeze where it's not an emergency situation, but for the most part, on average, if you have a patient with an inspiratory wheeze, that's something you want to treat right now. You're not going to say, okay, let me listen to your abdomen and, check your pedal pulses and that sort of thing. You're generally going to stop right there and probably treat that. Maybe it's something that they can use, one little shake of their inhaler and they're good to go. Maybe they need a nebulizer treatment. Maybe you need to go get some IV Cellucor-Tef. But you need to treat an inspiratory wheeze. The only time it's okay is when it was much worse before and now it's improving, kind of like that heart rate, right? The only time your blood pressure is crazy numbers is when they're getting better and you can't make them better in 10 minutes. So same with the heart rate, right? They were 120 and now they're, 105, and 105 is better than 120. So we're slowly getting there. But recognize that an inspiratory wheeze is more or less an asthma attack and they can't get air in. So they're having constriction in their airways, whether it is from inflammation, a histamine response, an allergic response, or they are having a flare up with an asthma attack or that sort of thing, which is generally constriction from, inflammation or something similar. There is a broad range. I only have so much time to kind of wrap it all up. But an inspiratory wheeze is an important thing, and you generally need to fix it quickly. That means they can't get air in. So I also might check their SAT and, their color. Look at their color here and their mucous membranes in their lips and that sort of thing. Are they truly having an asthma attack, or is that inspiratory wheezing from something else? Is it something they can cough up and clear if it's, just an upper airway issue? So recognize an inspiratory wheeze is not something you discharge. Bilateral inspiratory wheezes to bilateral upper lobes and, mid lobes and bases clear, to auscultation or whatever you want to say. That's usually something you need to jump on right away. So an inspiratory wheeze is probably, other than maybe a pleural friction rub, but you often don't even have to hear that sometimes. You walk in the room, they're clutching their ribs or their chest, and they are saying it hurts to breathe. And that you can listen, but asking them to breathe is the same as twisting the knife. So you may just, notify somebody, get a chest x-ray, see what we've got going on, and send them out because they may need some treatment, or if they're in the hospital, obviously they're going to hopefully get that treatment. So for the most part, your wheezing is a big concern because that's about your airway, right? So your pleural friction rub is in that pleural lining, right? Do we need to go into that pleural space, right? What should be in that pleural space? Right, good. Negative pressure that is holding that lining open. So if the lining of your pleural cavity against the surrounding tissue is inflamed, you'll kind of get that rub, that Velcro sound, and that should glide smoothly and quietly along that lining. So if you're getting a rub and grating and grinding, then there's some inflammation, and just that lining, as you breathe, that friction kind of rubbing up against that external lining is going to create some significant pain called pleurisy. The pain is called pleurisy, but the condition is called pleurisy, and it generally hurts to breathe. And once in a while, when a student comes to me and says, I think I hear a pleural friction rub, I'm kind of like, it's probably wrong, Kai, let's go check. And one time in 15 years did I walk into a room and this little old lady is clutching her chest, and she says, before I even, don't even take my stethoscope off, I look at her and she says, this is what it felt like when I had pleurisy. And I'm like, I'll be right back. I told the nurse, she shipped her out, got a chest x-ray, shipped her out, and she went on to the hospital to get taken care of. That's a pleural friction rub, and it's hard to hear over the screaming, basically, a lot of times. Or they won't breathe enough to where you can hear any movement, and they're very shallow because it literally hurts to breathe. So when we talk about the airway, that's generally a bigger concern, unless obviously there's a, systematic failure here. So with your inspiratory wheeze, you want to treat that quickly. An expiratory wheeze is more often kind of a little bit lower. Not that it can't echo throughout the lung, but it's often lower in those smaller bronchioles where the damage is so permanent and severe with your end-stage COPD patients or mid-stage COPD patients that as they kind of force that air kind of from their diaphragm through those narrowed airways, it's like and that's sort of like what you're going to hear with an expiratory wheeze. You may hear little inspiratory because it's that same airway that is jacked up on the way in and on the way out for the most part, but you'll hear it more consistently and louder with an expiratory breath. With that expiration, you'll hear that wheeze that kind of lets you know that there's permanent damage, not a lot you can do to help. And sometimes with pneumonia, it will go away, but you'll have to kind of look at the chart, see what they're there for, and see what's happening. But recognize that when we talk about any sort of wheeze, that is an airway issue, whether it's problems getting air in for something, that may be acute, or air out that is either pneumonia acute or a chronic COPD emphysema kind of thing, right? So when those alveoli are damaged, you know that chances are the bronchial are damaged also, and you'll kind of hear that. So that is your wheezing. Not that you can't hear it in different areas, but generally, from my experience, and I pay attention to other cases that were going on, not just the patients I've had in my career, but generally, your inspiratory wheezing is in your upper lobes because that's a loud airway issue that they can't get in. If it echoes lower, maybe a bigger issue needs treatment immediately. The expiratory wheezing, not that it doesn't echo throughout, but you might hear it more consistently and just louder in those bases or those lower lobes where the damage is, right? So and any sort of wheeze, that's where we're kind of going to connect that to our care plan. And we'll talk about care plans down the line with our ineffective airway clearance, right? So the next is your rhonchi. And again, not that you can't hear rhonchi throughout, but rhonchi generally is in your kind of upper to mid lobes. When it's even lower than that, that's when you know that patient does not have an effective cough. You want to, like, I always kind of think of like squeezing my leg in behind